Welcome everyone again to the University of New Mexico Law and Mental Health Didactic Series, hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. Thanks so much for everyone joining us here today. I'm Dr. Anthony Perillo, the Forensic Psychology Training Director in the Department of Psychiatry and Behavioral Sciences here at the University of New Mexico. For our talk today, as a heads up for a couple of things, if you have any questions for our presenter, you'll ask them in the Q&A box, not the chat box, the Q&A box, anytime that you feel comfortable. We do hold those off until the end. We try to get to as many as possible. For various reasons, just forgive us if we do not get to yours. For those of you that want continuing education credits, but are on a tight schedule, you do not have to stay longer than the full hour, though you do have to stay for the hour. I will try to let you know when the hour's passed. And for those that are pursuing continuing medical education credits, the sign-in sheet just got posted in the chat right now. And for those pursuing APA continuing education credits, that link will be posted around the last 5 minutes or so at the top of the hour. You will have to open the link before you leave here. We don't send the link out afterwards. And you do need to save your certificate after completing the survey because we don't have access to those. We will not be able to get you a copy of those. A recording link and PowerPoint slides for today, for those that have registered, will be available later today. And as a heads up for next week's talk in the series includes Dr. Anna Feynman, who will be discussing sovereign citizen beliefs and their implications on adjudicative competency. But for this week, now is the time that we've been waiting for. I'd like to introduce you to today's speaker, who will be discussing neuropsychology's role in forensic work. This is Dr. Nicole Graham. Dr. Nicole Graham is a clinical and forensic neuropsychologist in Fort Lauderdale, Florida. She earned her Ph.D. from John Jay College in New York City, where she trained in city and state psychiatric facilities, medical and rehabilitative settings, and in jails and federal prisons. She completed her pre-doctoral internship with the Central Regional Hospital and University of North Carolina Medical School. She completed a forensic fellowship at the Institute for Behavioral Sciences and the Law, and she has tackled an additional neuropsychology fellowship, which she is completing the second year of. In addition to all of this, Dr. Graham currently owns her own private practice encompassing forensic assessment for criminal, civil, and guardianship matters. Her non-legal work includes evaluations of dementia and traumatic brain injuries, including assessment of sports-related injuries for the NFL and NHL. In her spare time, she teaches undergraduate forensic and neuropsych courses at John Jay College and is a research advisor for additional graduate students. Dr. Graham, Nicole, on behalf of the University of New Mexico, can I just say how honored we are to have you join our series, and we're thankful for you sharing your knowledge and expertise with us. I'll now go ahead and turn it over to you.
Thank you, Anthony. All right, so the title of my talk today is The Role of Neuropsychology in Forensic Evaluations, a broad overview of the specifics. And so that's really what I'm going to focus on. Is I will have a lot of specific neuropsychological discussion and even some jargon in there, but the purpose is to provide a broad overview about of how neuropsychology can be applied in forensic evaluations. So as I will talk about a little bit later on, but the specific purpose of this presentation, because I believe it falls mostly within the realm of most of the viewership today for the UNM didactics, is it's going to be a focus on evaluations within the criminal realm as opposed to the civil realm. But I'll talk about that a little bit more in a few slides. Of course, the views presented here are mine and mine only, not of UNM or any other facility or agency. But so let's get into it. What exactly is forensic neuropsychology? So naturally, I went to ChatGPT to write my presentation for me, and it did a pretty decent job at providing a description as to what forensic neuropsychology is. Essentially stating that it is the application of clinical neuropsychology within a forensic context. So within various legal domains, such as personal injury cases, other civil litigation, as well as in criminal contexts, such as assessing competency to stand trial or evaluating the impact of neurological disorders on criminal behavior. more broadly speaking, most of the time when we talk about clinical neuropsychology or what is neuropsychology, it's often communicated that it is the relationship between brain and behavior. So how do brain disorders impact our thinking and about how we behave? And a lot of times we think about neuropsychologists as doing a bunch of testing and perhaps delivering treatment, or at least coming up with a treatment plan for those with these cognitive deficits. And the basis behind neuropsychological evaluation is this idea that essentially that the brain is broken up into different sections or lobes, and that each lobe is responsible for different areas of functioning. So we have the frontal lobe, which we learn about is responsible for executive functioning, attention, working memory. You have the parietal lobe, more relevant to visuospatial types of reasoning. You have the temporal lobe, and then where we learn about language and we talk about memory. And then sometimes in the back, we're going to be looking at, as neuropsychologists, sometimes we look at the impact of motor functioning. That is a really kind of black and white picture as to how we perceive the brain to work. It's not that concrete, but that is kind of the foundation behind neuropsychological evaluation. As neuropsychologists, we know about dozens upon dozens, if not hundreds of tests that go about assessing the different areas of brain functioning. And if there's been impact or injury to one of these areas, then we sort of expect it to show some deficits in that particular area or lobe of functioning. But beyond just knowing hundreds of tests and having stories memorized and list of words memorized to present to the patient in front of us, where I think the neuropsychologist comes into play is the second part of this definition. And that's communicating either to the patient, their family, or to legal stakeholders, an understanding about how a person's brain functioning, so perhaps dysfunctioning, what that has on the person's functional capabilities. So how they go about moving through day to day and how that impacts their performance, both in educational systems, vocational arenas, as well as incorporating their psychiatric functioning as everything kind of interplays together. And so that's where I think the neuropsychologist comes into play. It's more than just simply stating it's the role of the brain and behavior relationship. It is, but it's really understanding the person as a whole to be able to identify their strengths and their weaknesses and how that impacts their thinking, how that impacts their psychiatric functioning, and other psychosocial factors that go into this. But there is a specific focus on perhaps neurodevelopmental issues, such as things that might happen in utero or other cognitive developmental issues, as well as things that happen throughout somebody's life, acquired injuries to the brain, to the head, that are going to impact their functioning. So bringing it back to forensic neuropsychology, and I will certainly have to give props to Casey LeDuc for this definition, but essentially it's the application of really understanding the brain and behavior relationships as it can be informative within the legal system. And forensic neuropsychology has become increasingly more prevalent in legal settings. As you can see here, just a review of LexisNexis cases and the role that neuropsychology has played in various legal decisions. And when we look at the practitioner surveys that are kind of published in neuropsychology, we look we have seen forensic neuropsychology grow throughout the years, and it being more of a predominant area of focus that neuropsychologists participate in. But what you can see from this chart here specifically is that neuropsychologists who are engaged in forensic practice are more so engaged in civil matters. So a lot of times you're going to see the personal injury cases, as well as providing opinions about disability and workers' compensation. So you're not seeing in far less frequency, you're seeing the things that more of the forensic psychologists are doing, I would say more prevalently in their practice. And along with that conceptualization, you will see that one of the most prominent conditions that are being assessed for as the forensic neuropsychologist is the role of head injury, or TBI. Less so, very much less so, the role of psychotic disorders, which makes sense when you think about what you're assessing for in the civil realm and how that kind of plays out. But as opposed to if we were to look at what forensic psychologists are seeing most frequently, I would argue that it's probably psychotic disorder would be a much higher prevalence. So moving forward, as I had alluded to in the beginning, the rest of this presentation is going to look at the role of the forensic neuropsychologist in criminal proceedings. I have a couple of things thrown in there of the neuropsychologist as it relates to the civil realm. But for today, I really just wanted to focus on the criminal side of things, because as I said, I think that's where a lot of the audience members are coming from and what they practice in. And then second to that, I had thought about, should I go based upon the types of evaluations that we are usually seeing, so competence to stand trial, sanity cases, risk assessment, but rather I chose to, as we move forward through this presentation, I'm going to focus on clinical conditions that the forensic neuropsychologist are most likely to be a part of, and discuss how that plays into those various criminal evaluations. So a little bit of hypocritical here, though, I'm going to focus on TBIs as the first clinical condition. While I did say that that was one of the more prevalent conditions within the civil realm, it's also important to consider within criminal justice populations, because those individuals, the kind of research is mixed, and it's hard to really understand how many people have had a history of a TBI, but we know between 40 to 60% of criminal justice populations do have a history of TBI. And those with TBI are at risk of engaging in criminal behavior and other sorts of behaviors that lead to reincarceration and recidivism. But so when we think about TBIs, it's not as simple as just saying somebody had a head injury, someone had a TBI. Rather, the way we go about understanding TBIs is based upon a classification system, and there's different ways of thinking about this. And the point is not to get into the specifics of how we classify our TBIs, but just this idea that there are different levels of severity of traumatic brain injuries. Individuals, the most frequent kind are mild TBIs, but individuals can have more significant TBIs, and they can have different degrees of deficits for that person in the immediate as well as long term. Overall, we know that TBIs can have a range of deficits, both from a physical standpoint, but as well as cognitive and our emotions and behaviors. And the range of symptoms, it varies, and the degree and severity of symptoms are going to certainly vary based upon the severity of the TBI, as well as other psychological factors and contextual factors as well. We also know from, or as a neuropsychologist, we can recognize that an individual with a mild versus a moderate to severe TBI are going to have different expectations in terms of their recovery period. So within a mild TBI, we are going to expect recovery to happen rather quickly, and more so within about 6 months, with a year really being, you're going to see recovery pretty much within less than 6 months. But with the moderate to severe TBI, it's going to take a little bit longer to recovery. And within the first year, you're going to see the greatest recovery will have occurred, with some improvement thereafter, perhaps. But it's also possible that somebody might continue to have deficits and maybe won't be able to return back to baseline. But rather than get caught up in the specifics about the timeframes and the types of symptoms and severity of symptoms, what I want to communicate is that TBIs can have a range of symptoms, but we do have an understanding as to what types of symptoms we expect to see based upon the severity, as well as when we expect to see recovery. Now, one thing that will complicate that, and we really should consider when we're working with criminal justice populations, is the idea of repeated head injury, particularly repeat mild head injuries, particularly those that can occur close in time or with frequency. Just as an example that might be relevant to at least football fans is this past football season, Tua Tagovailoa, who had a pretty significant head injury when he was on the field. It was broadcasted across the world, and he had some pretty significant deficits from that. Then he was allowed to return back to play within a few weeks. And then he sustained another injury that, by the looks of it, I don't know, but by the looks of it, seemed a lot less severe, a much more mild kind of hit. But then he was out for the rest of the season. And so what's that all about? Well, because when you don't fully heal from your first injury and you sustain another injury, even if it's a mild one at that, it can still have significant effects because you're just more vulnerable to the effects of a head injury. So if we think about how that portrays in the kind of the real world, individuals who are at risk for getting into fights. And so outside of just a single fight, if you think about perhaps the youth who is in an abusive environment, so they are already enduring physical abuse. They might have been in an accident, such a car accident, a bicycle accident, and then they're getting into fights, and they don't have the 5-star treatment that Tua receives, so they're not getting the rest, the relaxation that the brain needs to fully recover. You can imagine that these repeated injuries to the head can have deleterious effects on an individual. So how does this relate within forensic evaluation? So it's possible, depending on the extent of the injury, that the person could have cognitive deficits that are going to interfere with competency to stand trial, such as being able to pay attention, learn, and remember information. But that's possible, but we do see that the brain can heal and recover. So competency might not be as prevalent of an issue, but I think it is important definitely to consider the history of TBIs as it relates to mitigation. And what I mean by mitigation is, are there mental health, which I use that term broadly as the law does a lot of times too, are there mental health factors that should be considered by the legal system to reduce sentencing outcomes or to go to kind of bottom of guidelines? And should those mental health factors be considered in diversion? So does an individual's history of TBI symptoms, so that's both the cognitive deficiencies that might be related, as well as the psychological symptoms, the mental health symptoms that we see associated with these cognitive deficits or head injuries, did that lead that person into a context of engaging in criminal behavior? And should it be targeted in future treatment? And it can also be important for risk assessment. So, and I think about this as both the immediate consequences of a TBI as well as the secondary consequences of a TBI. So the immediate consequences are, as I've been talking about, the cognitive deficits, the psychological deficits, the mood, the irritability, the anxiety that can come along with TBIs. But then just the change in that person. So when we sustain an injury, it changes the way we might think. So we're not thinking as clearly. We might not be as to the point as we were. We might not process information as quickly. We might have word finding issues, etc. So that's really could be a hindrance on who we are as a person in the education realm, in our professional realm. And so that can take its toll on us as individuals. And so if we're not functioning at the same high rate as we were previously, then how is that person moving through life? And that's kind of going to be the theme that I want to get to, is looking at the person as a whole, both with the cognitive struggles as well as kind of the collateral consequences that go along with that. I will say as well, this is particularly timely. Actually, I just received a case wherein the person whom has a pretty much like a blank slate, no history of criminal behavior, just an average individual. And they had sustained, from my understanding, it's brand new, but back-to-back head injuries, one more mild and then one seemingly a moderate to severe TBI. And then basically went on this week-long crime spree. So it will be interesting to find out, both from a mitigation as well as a risk assessment perspective, as to whether or not this individual has started engaging in these very impulsive, disinhibited behaviors as a result of the TBIs, or did the TBIs set off perhaps like a prodromal type of maybe a bipolar disorder or something. But so that's exciting, and I don't have any information on it, but that's really kind of bringing the role of TBIs into forensic evaluations. Now, this example is I'm about to provide to you is within the civil realm, but I think it's important to think about, because the reason why I stress so much is this kind of understanding the symptoms and the time frames and the severity levels of TBIs, is because that helps us as neuropsychologists to understand is who the person presents as today, the deficits that they are presenting with today, is that consistent with what we would expect with the degree of TBI that somebody experienced, or does it seem inconsistent or perhaps feigned or even malingered? So like I said, this is a personal injury case. It was a young adult who was involved in a rollover accident. The accident actually seemed pretty bad, but the what you see here on this screen is records from when EMS arrived on scene, and basically saying the person was, in terms of cognition, he was fine. He was cognitively intact. He was oriented. There was no loss of consciousness. So nothing was broken. He was in pretty good condition despite the accident being pretty bad. So we would probably think about this as a mild TBI. So when he's seen for neuropsych testing 2 years later and is having these impaired performance across memory and attention, that would be pretty suspect. So that's kind of where the neuropsychologist would come in to say, well, the injury isn't adding up to these deficits that are being reported, both self-report as well as seen on testing. And the validity testing would agree that it was not genuine performance. All right, so moving into another condition, or a couple of other conditions that a neuropsychologist can come into play. Stroke or seizures. I have them lumped together, but they are not necessarily related. But it's just to say that neuropsychological deficits are really kind of contingent upon the location, severity, type of stroke or seizure, as well as whether or not somebody received treatment. I'm not going to get into the different types of strokes or seizures, but what I think is important here is an understanding that when individuals have these in their history, that it can have deficits, and that attorneys don't always understand or recognize that. And again, rather timely, I have another evaluation where the court had asked the person to get a mental health evaluation. The attorney told the client to call me to schedule that. And on the phone, and trying to get that scheduled, it was evident that something was off. Could have been psychiatric, but really seemed to be some cognitive issues there. And I spoke to the attorney about that, and I suggested that neuropsych would probably be important, and actually competency is probably really where we need to start with this person. The individual had relayed after some deficits in communication that he had recently had 2 strokes. So so this is just an example as to where, to the attorney's perspective, it's like, yes, this person seems off. Send them to the psychologist, and certainly it's within our expertise to kind of disaggregate what is off about the person. But from a logistical standpoint, and also from a legal standpoint as well, as to what types of evaluations we're going to do. But if I'm seeing someone for neuropsych testing, that's going to be a much longer day than it is if I am employing only psychological testing. And then another example, which I'm trying to be cognizant for time as well. I have a lot of slides, but this was another individual that I saw who had a history of stroke, of 2 different strokes, actually. His first stroke, I don't think you can see my pointer, but his first stroke happened probably about a decade before I had seen him. And that was in the right posterior cerebral artery, so in the back right side of the brain. And then a few years later, he had a left MCA stroke, so left middle cerebral artery. And he was referred to me by defense for whether or not he was competent to stand trial. And so when we have strokes in various areas of the brain, we expect to see different types of neuropsychological deficits. And so I kind of had mixed history of information as to what types of deficits this individual demonstrated in real world functioning. But what was evident with me was communication. His language was off. And we would expect that with somebody with a left MCA stroke. I won't get into the specifics, but there's different types of language deficits. We want to know if they're having problems producing or expressing, speaking, versus comprehending or understanding, or do they have problems across the board? This person, his receptive, so his ability to understand language was a little bit better than his ability to express, but it was still pretty weak. He really could only understand and respond to basic prompts, as opposed to being able to understand and engage with the complex reasoning that would be necessary for competency-related abilities. So, as if I was wearing my hat as a psychologist, I would recognize that, there's some cognitive issues here that's evident. And I would read the records, and I would probably be able to inform that these deficits are a result of his strokes. That would probably make the most sense. I would likely come to the conclusion that he is not competent because in the least he cannot communicate neither verbally nor in writing. And it also seems like he's having some difficulty understanding what I'm saying to him. And then I might, as a psychologist, fall back on an unspecified neurocognitive disorder because I wouldn't be so certain as to the cause or the etiology of the deficits, or really the specific deficits. And as a psychologist, I'm not sure if I would be able to provide the courts with kind of a clear, educated opinion about restoration. Whereas the neuropsychologist could potentially come in with testing to discriminate the language deficits and the severity thereof, and look at other domains of functioning as well. and perhaps have a more informed conclusion for the courts in terms of prognosis for restorability for these individuals. I think I'm going to try to really speed through intellectual disability because this really falls within the realm of both psychologists and neuropsychologists. And certainly psychologists utilize the ways and diagnose intellectual disability all the time and as it relates to competence to stand trial. Where I think a full neuropsychological evaluation can kind of go above that of the WACE alone is to really understand somebody's cognitive strengths and weaknesses. So even if they do have an intellectual developmental disorder or other neurodevelopmental conditions or an overlap thereof, a neuropsychological evaluation can look at those different domains that I had spoke about earlier: language, executive functioning, attention, memory, perceptual reasoning, and all those things, to really understand where this person does well at versus where their weaknesses are. And with that, you can use that information to help understand how can we really emphasize that person's strengths while trying to work on their weaknesses. And I'm pulling in this slide from earlier in the presentation where I think it can be very important to understand somebody's cognitive strengths and weaknesses and how that affects them as a whole person. So really understanding both their cognitive abilities as well as their psychiatric functioning and how that plays into who they are as an individual and how they move through the world in relationships, in education, in getting a job, having housing, seeking medical or mental health help, etc. And I can particularly see its utility when we speak about youth or those who are in that kind of younger age range. So they're not classified as a juvenile anymore, but they are still in that realm of their brain is still developing. So in the early kind of 20-year-old age range, where it is important to understand both brain development as a whole, just standard normal brain development. But then if you take this individual whose brain is still developing, like a 19-year-old, and then you throw in there, oh, hey, when mom was pregnant with him or her, mom used alcohol or drugs. And then this person had a lot of head injuries because they were physically abused. They were in a car accident. They played football and they kept getting knocked out. And oh, by the way, they've also started doing drugs when they were 14 years old. And so you have a brain that's still in development, and then it's hit with all of these other factors that are going to further hinder the brain's ability to develop along its normal trajectory. And then when we employ neuropsychological testing that can provide the kind of objective data that can show, hey, not only is this person's brain still in development, because we know that from neuroscience, but they're even a few steps behind because they've had all these insults or injuries that are further going to hinder, and that's demonstrated on cognitive testing. So again, I think that a full neuropsychological evaluation can be helpful in certain situations in trying to understand the person as they move through the world. And it's not just about cognitive functioning, but that certainly can give somebody the resources to succeed or not be as successful when we think about regulation of emotions, interactions with other people, impulsivity, perspective taking, etc. All right, so coming back to the role of psychotic disorders and schizophrenia, where we don't see this a lot with the practice in the civil realm, but we definitely see it in the criminal realm. And we know that schizophrenia is associated with neurocognitive deficits. The research has not really been able to provide a specific profile of what deficits are consistent with schizophrenia. But by and large, a lot of times we will see these individuals struggle with verbal learning and memory, and then also see some of those frontal systems like attention, processing speed, and executive functioning be particularly impaired with these individuals. And that's even when they are adequately treated from a psychiatric standpoint, they're still going to have these cognitive weaknesses. So this is an example of an individual that I saw, a middle-aged person. They had murder charges from probably many years ago, really. And I would say they had difficult to treat schizophrenia. It's not treatment resistant, but it took a lot of different trial and errors, as well as a lot of negative allergic reactions to some medications. And so when you're moving this individual from jail to hospital to different jail, different hospital, it can get very frustrating and trying, and just time added on and everything else for this individual, because the medications oftentimes change every time you move somebody around. So with that being said, there were numerous opinions about him being incompetent to proceed, or incompetent to stand trial. And sometimes clinicians would think that he was competent. Usually that was in the context of being at the hospital and observation and treatment, et cetera. But overall, all of the clinicians always diagnosed him with schizophrenia. So then I come along and I am retained by the prosecutor's office with questions as to whether or not he's competent, but more so, is this person restorable? And so when I first met with him, I met with him on 2 different days. I kind of wore the hat as a psychologist, and I saw this person as being, from a psychiatric standpoint, they were stable. So as a psychologist, I'm like, he's stable. He's actually pretty insightful to his history of schizophrenia, but he's still not firing on all cylinders. Something is still a little bit off. The memory wasn't great. The reasoning wasn't great. And I couldn't tell if he just wasn't trying that hard, really didn't want to talk to me, or what was going on. So then I put on the, neuropsychologist hat. And I said, all right, let's get some testing with him to see really what's going on. And in the context of valid testing, we did see that he was struggling. Now, intellectually, baseline abilities were pretty low to begin with, which was consistent with his history. But we also saw those learning deficits, as well as executive functioning or ability to reason with information was problematic. So I don't think I would ever be able to differentiate or disaggregate the baseline intellectual deficits that he presented with versus years of dealing with schizophrenia and the cognitive deficits that come with that. But what I do know is that now I could tell the court that this person's psychiatrically stable, and to keep him on these medications that he's doing well on, but that he still has these cognitive problems, and that now there's a new area, or actually kind of a new venue of services for which he can go and get competence restoration that can target these cognitive weaknesses, rather than the venue only looking at the psychiatric functioning. So again, first I kind of played the role as psychologist, and then I put on my neuropsychologist hat to engage in testing and to inform competence and restoration. And this also goes beyond just competency. So as I was saying earlier, individuals, even if they're adequately treated from a psychiatric standpoint, they can still be at a disadvantage when it comes to functional abilities when they are released into the community. So it is important to understand where somebody is at cognitively who does have a long history of schizophrenia or other sort of psychotic condition. Substance use. This is really where the psychologist certainly falls within their realm of diagnosing, treating substance abuse, recognizing substance-induced psychosis, how it informs risk assessment, and all of that. But there are certainly cognitive effects that come with longstanding substance abuse. And there is some idea that classes of drugs can lead to specific neuropsychological profiles. I don't necessarily agree with what's presented here. It's dated, as well as I think the research in this area is always continuously evolving. And so we see deficits. It's not as clear cut as this, plus the people we work with typically don't just stick with one class of drugs. But suffice it to say that these individuals can have cognitive deficits, those who engage in long-term substance abuse, that can be on the more mild end to more severe ends of deficits. All right, dementia. So usually we're not going to see somebody, it's on the more rare side that we are going to see a person in older age being involved in criminal behavior, and just the idea that we tend to age out of engaging in that type of behavior. But it's certainly possible. And symptoms of dementia can be associated with disinhibited behaviors. So if you think of the stereotypic like grandma or grandpa who says something that's a little bit crude and has no concern about how other people might feel or react, it's kind of like that, but on a more severe range. So we can see sometimes this happens where individuals who have pretty long neurodegenerative conditions that are kind of towards their middle to later stages, in which these individuals can be aggressive even towards loved ones. They can engage in sexually inappropriate or sexually unwanted behavior. Sometimes we will see that in nursing homes and things like that. It is important to understand that dementia, I think in mainstream media, is used as synonymous with Alzheimer's disease, which isn't true. Dementia is more so just an umbrella term to describe an individual who has significant cognitive deficits that are interfering with their day-to-day functioning. Alzheimer's disease is the most common or prevalent type of dementia, but there's many different types of dementia. And these different types of dementias have different neuropsychological and psychiatric symptoms that present. And as the neuropsychologist, again, it's not black and white, but when we look at someone's earlier symptoms and dependent on the specific deficits that they're showing, we can start to have educated guesses and hypotheses as to what type of dementia that we're likely looking at. So how does this come into play within forensic evaluations? It is possible, I would say, it's going to be on your more rare type of encounters, but it is possible that somebody would have a neurodegenerative condition and also a dementing condition in which they really just engaged in a behavior and didn't understand the wrongfulness of their actions. But really, even before we get to that point, we would want to make sure that this person's even competent. If they're having these cognitive deficits, are they competent even to move forward with the defense? And Arias and Flicker actually proposed that individual aging populations should be treated in the criminal justice system similar to that as juveniles, when we look at the role of how brain functioning impacts behaviors and how that differs both in the earlier versus later stage of life. This case, which went on appeal, but ultimately Vernon Madison, who was on death row for multiple decades, was ultimately declared not competent to be executed based upon the type of dementia that he had. And so I know I'm glossing over a lot, but it's really to just kind of show you the different types of dementias and the symptoms and how this can impact various criminal evaluations. And so I do want to talk about the behavioral variant of frontotemporal lobe dementia. While it's more of the less frequently seen dementias, it is interesting because this type of dementia can happen much earlier in life than we see with Alzheimer's disease. So onset can happen within usually like between the 40s to 60s age. And that's important to consider when we think about criminal behavior. Individuals with this type of dementia can have significant personality changes, which can also come with it impulsive, disinhibited behaviors. And when the person, and when this develops at a younger age, we as clinicians might be more quick to think, were they on drugs or alcohol, or is this a manic episode, rather than to go and think that, oh, this person must have dementia. It just doesn't line up with our stereotypic views of kind of how we think about dementia. But it can occur earlier in the time frame. And this is just a short video of an individual who has demonstrated significant personality changes. This person is a father. He's a father of 4. He was married and he's young. He is not engaging in impulsive or any sort of impulsive or aggressive behaviors, but from this video, you will be able to see how somebody's both their affect and just complete demeanor can change. And what you will notice too in here is that he can be a little bit just not recognizing the situation. And so his verbal responses could be considered rude. We know that they're not because of his condition, but if he said that maybe in public, then that would have been construed a little bit differently.
Friend of mine, and I told him they need to bring the big camera. This is Bill.
How are you? Very nice to meet you.
You interviewed Mark Johnson at the nursing facility, and you saw close up what this disease has done to him.
You understand why you're here?
No.
Think you'd be okay at home?
Yeah.
It was very difficult, sad.
As she told us about her visits, they have 4 kids, 4 very young kids.
Brian, you gotta take your backpack off, honey.
He'll kiss the kids, then after just a couple of minutes, he's done.
Yeah.
He wants them to leave.
He did that with you.
The same. It's
Yeah.
like, bye. I don't want to make you uncomfortable.
Okay, see ya.
Okay. Okay, see you. Mark, it's real nice to meet you.
Then you can go lay in bed for a little bit, okay?
Okay.
And I talked to Amy a lot about
Okay, so you can just tell by looking at him that this is a younger individual where this neurodegenerative condition has really completely changed his life and his family's life. And actually, it's been popular in the media. Bruce Willis has been publicized for he has a different type of FTD, the language variant, but the behavioral variant, we can see individuals engage in criminal behavior more so in this type of dementia than in Alzheimer's disease. And the behaviors can be more serious. The criminal behaviors can be considered more serious than those with Alzheimer's disease. And like I was saying earlier, when they do engage in these problematic behaviors, the person's pretty young and it tends to be earlier in the disease onset. So the family they recognize something's off about their loved one, but they're probably still in getting tested by different professionals and not really understanding what's going on. So when there's significant behavior change, a lot of people are left confused. And this is just one example of an individual who was found in GRI, in part because of FTD. Okay, so I could not have a neuropsych presentation without speaking about validity. The idea of validity is one of the most popular topics in neuropsychology that's evidenced in the publications, the amount of different training opportunities. And if you are a part of any neuropsych listserv, it's a topic that comes up multiple times a week. So as a psychologist, and I might be speaking a little bit dated based upon my training, but I remember learning about validity testing, and it was more so referred to as we were looking at feigning or malingering. Whereas in neuropsychology, we're looking at, or at least using the terms validity testing. So certainly validity testing comes into play within the psychological realm. And so we're looking at symptom validity. So is this person exaggerating, or are they minimizing their psychiatric symptoms? But within the cognitive domain, we want to look at performance validity. So is this person putting forth their best effort on tests? Are they saying, I don't know, I don't know, I don't know, because they truly have memory problems? Or they're not interested in participating, or they are attempting to feign or malinger having a brain injury. And so I think where the neuropsychologist can come into play here is they have a pretty broad range of tests that can assess for performance validity. So whether or not someone's putting forth their true level of effort on cognitive tests. And the tests are both standalone, so measures that are just meant to assess for validity, like the TOM. But then we also have embedded measures. So within our measures of cognitive abilities or cognitive tests, we have cognitive tests that look at a specific domain, but within them, we can also assess for effort. So this was one that I just completely made up with the help of ChatGPT again. But essentially, what might happen is I would read the person a short story about this woman. She lived in a small village. She went into town one morning to do her grocery shopping. And on the way, she found a little girl who was upset and crying. And I would read this story to the person. And then later on, I would ask them some questions about the story. And so on the one hand, this is meant for me to know, hey, how's your memory? Do you remember the details of that story? And so that would give me a degree of their memory abilities. But there might also be an embedded measure in here. So I'm completely making this up, but let's say if they did receive 2 of the 3 questions correct on my questionnaire here, that would mean cognitive impairment. But if they could only answer 1 question right, well, then we pretend the research says, oh, you can only answer 1 question right. Well, that's been associated with people who have low effort. Now, certainly your assessments are going to have more than 3 questions there. But this is just an idea of what an embedded measure might look like, where I think neuropsychologists can really come into play in going about and assessing whether or not somebody's putting forth genuine effort on these tests. And this is a big focus in neuropsychology, and we do have criteria for establishing whether or not somebody's malingering, and we can have debates about whether or not to use the term malingering. But the point here is, and this is a very short version that I typed up for it to fit on the slide, but to recognize or to classify somebody as malingering. And what I would like to focus on here is C. And that's what I had been speaking about earlier when I had shown the example of the TBI. So was the deficits that the person presenting with consistent with what we would expect of somebody who has a TBI, particularly a mild one, and particularly 2 years later? Or is their presentation of cognitive deficits really not consistent with what we would expect of this neuropsychological condition? All right, so I have 5 minutes left. I will stay later for questions just to get through the last couple of slides. 2 of the, I would say, are the biggest ethical issues that neuropsychologists deal with on a day-to-day, at least in the current time. There's going to be the focus of my next couple of slides, but the first one being our choice in norms. This comes into play across the board for psychologists, neuropsychologists, across testing, assessment in general. But where there's money, there's media and scrutiny and everything else. And so one of the big things in the media right now is this idea of race norms, and that how the NFL went about the norms that are used in qualifying former players based upon their neuropsychological test performance and the norms that are used to classify whether or not somebody demonstrated impairments or not is a big thing in the media, a big lawsuit recently, and et cetera. But we take out the money and the settlement and all of that, take that aside. How we go about our testing and understanding what populations and what norms we should use should be centered to any assessment practices, and is certainly present in neuropsychologist setting, because we see individuals of various backgrounds and cultural differences and whatnot. We don't always have rarely do we have a perfect sample to compare somebody to. And so that is something that we face regularly, is recognizing what samples to use, because it does have significant implications as to, we certainly don't want to say somebody's impaired when they're not, but we also don't want to miss calling out the deficits if the deficits really are there, because that can impede somebody from getting services and things like that. And then finally, one of the other ethical issues that I see as being one of the most prominent in forensic neuropsychology is the role of third-party observers. And so this can be an attorney or an agent of the attorney sitting in the evaluation, so either the interview and or neuropsychological testing, but it can also be any sort of recording device, so audio or video cameras recording the evaluation. The American Academy of Clinical Neuropsychology has taken a stance and strictly opposes the role of third-party observers in any forensic or medical legal evaluation, stating that it's a threat to the reliability and validity of testing. It violates test security and our ethical principles that we uphold within the field of neuropsychology and psychology. So this is probably, I'm making this up, but with validity being maybe at the top of listserv conversation, this is probably the second most prominent listserv conversation, is how to navigate requests for third-party observers and having those conversations with attorneys and the legal system. And then as the neuropsychologist, dealing with that ethical conundrum. And then even further within the state that you practice in, because states vary with what stance, if they've taken a stance and what stance they have taken from a legal standpoint as to whether or not there can be third-party observers. Okay, I made it through. So I will take questions.
Thank you so much, Nicole, for that very thorough and helpful overview of what this can and perhaps wouldn't be in certain situations. As you might be able to tell, we have several different questions, and I've noticed that a lot of them are even about, kind of our audience anticipating, what if I get this referral, and what do I do in certain situations? So I'll read a couple of those first to get your input. First question here prefaces, thank you for your insights on the need for neuropsychologists regarding intellectual deficits and competency. Intellectual disability is something that clinical psychologists are well equipped to assess and discuss. Wanted to gauge your thoughts on neurocognitive issues such as dementia and competency evaluations. Do you think neurospecialization is necessary to effectively tackle those evaluations? Or are general clinical psychologists also equipped to tackle neurocognitive presentations in the context of competency evaluations?
Yeah, so I think that general kind of the broader clinical psychology field can definitely provide an opinion as to whether or not somebody is competent based upon a cognitive condition. We have the DSM, and it has neurocognitive conditions that clinical psychologists should rely upon. I think where the more where neuropsychological testing can be informative is for how to target, first of all, restoration prognosis, as well as how to target restoration. Can this person be in a group setting versus an individual setting? And do we think that this person can learn from repeated instruction paired with written feedback as well as verbal feedback? Or is it unlikely that this person can benefit from? Are they within a neurodegenerative condition that's just going to progressively decline and they're not going to improve?
So then kind of integrated into that, someone wanted to clarify or just confirm if someone has had education, training, and experience in administering neuropsych measures, but not a formal neuropsych postdoc, and they caution the referral source they're not board certified, would that be sufficient in terms of doing neuropsych testing in a forensic context?
Okay, so I think that the board certification thing, that's kind of like a separate piece, but there's kind of training guidelines, and we can talk about the Houston conference guidelines as to designating oneself as a neuropsychologist. And of course, kind of board certification is the gold standard or the highest that you can achieve. But yeah, I think it's about whether or not you have the expertise as a neuropsychologist, first of all, in the testing and recognizing what testing to use that's appropriate for the population. And it's not just about administering the test, because a lot of people can learn to read a list of words and write down whether or not the person learned the list of words. It's the interpretation. So is what we are seeing, is that because of a dementia, or is the role of depression and anxiety impeding their attention, so they're really not even learning to begin with to remember information? So that's where I really think it's the neuropsychological training that comes into play to be able to adequately interpret it. So as a psychologist, you might get trained in like the R bands, which is more so a screening measure and can't necessarily help us discriminate deficits, types of deficits, but it can say that this person is exhibiting deficits. And so you can rely upon that, but then to further extrapolate that and provide more so the interpretation, I think, is really where that falls into the realm of the neuropsychologist.
Absolutely. Thank you. This is, I guess, a related question, perhaps on the other realm of this, has a little bit of a setup. But I'll just read it verbatim here. That given that best practices in forensic psychology indicate the crux of a competency to stand trial evaluation is the functional competency interview to evaluate if the person has functional competency related abilities to proceed. If the defendant is referred to you as a neuropsychologist, even if the reason for referral includes neurocognitive concerns, do you inform the referring party of this and let them know either that you may not conduct neuropsych testing depending on the results of the interview, or that it may be more appropriate to have a forensic psychologist do the evaluation first, and if they find functional deficits during the evaluation, then refer for further neuropsychological testing?
Okay. I think I want to preface this with saying I try to be as practical and to practice within the context or kind of the political standings in which I am within. And there's three kind of overlapping counties with which I practice, and each county has their own sort of characteristics. And so when we talk about competency to stand trial, this goes throughout the country, even though each of the counties that I kind of practice in have their own characteristics. Throughout the country, we know that there's a huge competency backlog and the issues therein. And so I think the most important thing for an individual is to be seen by a competent forensic psychologist or neuropsychologist and provide an opinion about competency. And if that is due to a neurocognitive condition, then you can state that, and you can state that, you know, I might not have the expertise in doing the testing or providing you the specifics but it seems to be that there are issues here that need to be explored more. I'm being cognizant that it might not be the most informed opinion, but with such a backlog, it's important that a competent person is seeing this individual that's trained in forensic evaluations, and then let the person be seen when we talk about competency. And then to kind of move into the other issues of the neuropsychological pros and cons. And so while it would be great if if a neuropsychologist could then see that person and provide their opinion, the reality of the situation, at least where I practice, that probably isn't going to happen. And I think it's most important that somebody see and provide an opinion to intervene. Yes, this person's competent, move forward, or no, there's something going on, let's get some intervention. In a perfect world, I think my answer would be different, but it's not a perfect world.
As people, across many of these jurisdictions and the competency crisis going on, we are definitely not in a perfect world in that realm, for sure. Someone had a question piqued by your final discussion there about third-party observers, and wanted to hope you could talk more about that. And I think their curiosity, they're saying, are these third-party observers, are they expert witnesses, other neuropsychologists, or a psychologist credentialed in a specific way? And then also, in what types of cases are they most often being requested?
So I see the request more so in the civil litigation more than I've ever seen in forensic and criminal. So definitely civil more often from my experience. And the third, and who are the observers? The observers are typically going to be the attorney or somebody that the attorney sends in their place to watch. But so, and then in terms of the role of, they're not sending other neuropsychologists or psychologists to watch the evaluation, which leads into another issue of who we send our test materials to and things like that. But I'll keep it at that.
Okay. Another one that has a little bit of a setup, and this gets back to the referral question too. Legal parties can often be enchanted by neurocognitive testing without a full understanding of its appropriateness. What is your approach for deciding to administer testing when the referring party has misplaced assumptions about neurocognitive deficits? For example, if a competency referral includes concerns by the attorney about memory impairment and the attorney wants testing, but after your clinical interview, you find the examinee to be competent with no overt memory deficits, would you still choose to administer memory testing to satisfy the referring party or minimize the likelihood of testifying?
Yeah, so yes, neuropsychological testing appears to be this kind of mystical thing that's going to solve all issues, I think. And I think there might be some people that practice in the way to which that can get further supported, but that's also by using dated testing or testing that might not be appropriate for the question and making assumptions far outside what the test is actually showing. So if we think about kind of the ethical approach to engaging in testing, I try to have a conversation with the attorney about potential deficits and deficits that we might see based upon whatever the injury or condition was. I don't want to completely say it's impossible because I don't necessarily know. And a lot of times the attorneys don't particularly know the details too. So I don't want to jump to conclusions that X, Y, and Z are not possible because I haven't even seen the medical records the attorney has. And then sometimes the attorneys do characterize their clients in ways that aren't always accurate, but I don't know until I actually meet with the person. So if I'm in the middle of an evaluation and it's evident that either the person's not being fully effortful or it's clear that they don't have memory impairment, then I'm not going to engage them in a long battery of testing. Maybe I might try a screening measure to see if there are memory deficits present, but ultimately I'm either going to stop the interview. It depends really on the referral source, if it's private versus court order, et cetera, but probably stop and have a conversation with the attorney and say, this is what I'm seeing or thinking. How do you want me to move forward? But I'm not going to put somebody through 5 hours of testing that doesn't need that.
Excellent. With how intensive these can be, certainly. Going along the lines of screening measures and all that, somebody asked if you could recommend a TBI screening tool that the advocate could use to help determine the best forensic expert to hire for an evaluation.
So I don't know how the information from the screening tool would educate upon what expert to hire. But I mean, I like just to screen for TBI, like the Ohio State University's TBI screening measure that has like a shortened one and an extended one, which can talk about the deficits that are symptoms that a person had immediately after and then the long-term symptoms. So that might give the clinician some information as to what deficits that they continue to experience. Nothing from a screening measure is going to tell you what type of expert to hire.
Fast forwarding all the way to to potentially testifying, somebody asked, how do you respond to cross-examination questions that seek to show a defendant's clinical symptoms are not in sync with your presumably neuropsych evaluation results?
So I think that depends definitely on what you are testifying about. But I see this a lot with people who have histories of TBI, wherein immediately after the injury, they most likely were probably experiencing symptoms consistent with a TBI. But by the time I see them 2 years later, the brain does what it's supposed to do, and that's to heal and return back to your abilities. And so that person might be functioning normally now, but 2 years ago, when they committed their crime per se, they weren't. So in that case, I'm really looking for collateral information to substantiate. If in the present moment they are reporting symptoms that are not consistent with my evaluation, then I'm going to say that, and that's probably is going to inform my diagnostic opinion anyway.
And since we are getting close on time, I'll wrap up with one final question here. This is about what data that you report. Somebody says, while I understand that raw data is only supposed to be released to the opposing counsel's expert, do you include other data such as T-scores in the report? I'm assuming for neuropsychological testing specifically.
In my reports, I provide T-scores and percentiles, yes.
Excellent. Are there any considerations in terms of neuropsych numbers and data in terms of like what you would or would not put in a forensic neuropsych report?
So I do not put raw scores of any test. I do not put in cutoff scores for our validity measures. I don't say this is the cutoff score and they performed here. So when it comes to describing tests, I don't do that. When it comes to test results, just the broader neuropsych test results, so memory, language, etc. I kind of vary on my report writing style to what I feel is most informative to the court, is easier to digest as a non-clinician. So attorneys reading it. So sometimes I might just, rather than going test by test or domain by domain, some days I talk about this person's strengths and this person's weaknesses. Other times I go domain by domain. But I try to be as user-friendly as possible. I know there are other people who choose to, maybe not purposefully, but their writing is much more scientific and it sounds great and smart and mystical, mysterious. But I tend to go the other way and try to provide it in layman's terms.
Wonderful. Dr. Graham, Nicole, I want to thank you so much for joining us and both sharing, overall giving people an idea of the appropriateness and what they can and can't do in forensic neuropsychology, and responding to a number of questions across the neuropsych evaluation process. That wraps up this week's Law and Mental Health series. Again, next week we'll have Dr. Anna Feynman covering sovereign citizen beliefs and their implications on adjudicative competency. I hope you have a great rest of the week, and we look forward to seeing you again. Thank you, Dr. Graham.